Hello, I'm Dr. Kolesnikova.
And I'm Dr. Shakiba.
And today we're doing a session on the myths and misconceptions of endometriosis. So we see a lot of patients every day in our clinic who come in with pelvic pain, possible endometriosis. And with that, we see a lot of misunderstandings about the condition, the way to diagnose it, to treat it. So today with Dr. Shakiba, we thought we'd go over some of the myths and offer explanations.
Part of the problem with endometriosis is, despite of it being a very, very common condition affecting approximately 10% of women, there is still unclear reason why is this happening and its relation with the pelvic nerve issues.
So let's start with our first one, ovarian cysts. Extremely common, but do you think that they're the main cause of pelvic pain?
That's actually a big one. I'm sure you saw many patients that they go to ER, they do the ultrasound, and there is a 2-centimeter cyst or a little complex cyst, and they say, oh, your cyst was burst, and that's why you have pain. And the next month they are still in pain. They go, the cyst is no longer there, but they still have pain. So patient and even our clinician get confused. So what's really causing pain? The fact is, the ovary's job is ovulation, but the amount of pain is not necessarily is related to ovarian cyst per se. And main reason of pain is the inflammation in the pelvis affecting the nerve. Because of chronic inflammation, the nerve get more hyper excited. So by nature, those nerves are more irritable, and even ovulation is more painful. That normally should not be painful, but on the endometriotic patient, even that stimuli could be painful. The bottom line is the cause is not ovarian cyst. The cause is inflammation leading to hyperstimulation of the nerves.
To summarize what you said briefly, pelvic pain that comes from ovarian cysts can happen, but that pain is brief and occasional. Patients who have chronic pelvic pain, there's more going on. Let's talk about another common thing that we see. So a lot of patients come in and they say that I've had many ultrasounds, but they don't see anything on the ultrasound. So does that mean everything is normal?
So it is often a mystery to the patient that they feel something is seriously wrong, and then they keep going to their doctor, or they go to emergency room when they have a breakout and pain is intense, and every time all the blood work and most importantly imaging are negative. This is a very common feature on endometriosis patient. It is important to know that in medicine, we treat the patient, not the imaging, not the MRI report, not the ultrasound. And in a way that we think if the ultrasound is negative, that means nothing is wrong, and maybe the patient is crazy, or patient herself thinks is crazy. But it is important to know that the nerve's job is to inform you that something is going wrong. So if there is pain, there is bladder dysfunction, if it's a urinary urgency and we can't find the cause, it's definitely there is a cause. It just is not visible on any sort of imaging. And endometriosis by nature is not very visible. It's creating a very superficial inflammation that can get deeper and become visible in case it involved the ovary or sometimes deeper nodule in the pelvic area. So then it becomes visible, but that's probably a very advanced stage of endometriosis. Majority of them are not visible. The example I use is when you have an active wound on your skin, or you have a skin mole. If you get an MRI, that MRI would be negative. So that's the same concept. The problem with endometriosis is this wound or this skin mole is happening inside the pelvic cavity. So won't be identifiable by any sort of imaging. So take-home message is that negative imaging does not mean there is no disease or endometriosis involved.
Speaking of endometriosis and where it's located in the pelvis, if a patient is having severe bladder pain or they're having a lot of problems with their bowels, does that mean that the endometriosis is inside the bladder or inside the bowels?
Well, that's actually a very good question, and that's another myth about endometriosis, that the bladder symptom, it not necessarily mean that endometriosis sitting on the bladder. Bladder could be completely normal and have zero involvement, and the patient still have the symptom. And the reason is the nerve that go to the bladder have a problem. So the best example for it would be the light bulb and the wire in the wall. So if there is a problem in the wire behind the wall, that light bulb is still gonna dysfunction, not gonna work normally. Same concept apply here. So not necessarily always is the light bulb problem. Sometimes it's the wiring in the wall. And in the case of endometriosis, based on our experience, we see a lot of this. I mean, patient have a bowel symptom, but there is nothing wrong with the bowel, and we see there is an implant sitting on the nerve. Once we remove it, the bowel symptom goes away. And we're actually publishing a paper in this regard, especially about the bladder. So again, take-home message is you have a bladder problem and your known case of endometriosis not necessarily mean endo is sitting on that organ.
So what you're saying, these things are all connected through the pelvic nerves, which is how you get bladder symptoms, bowel symptoms, and everything
Exactly.
else.
If many organs in the same neighborhood are affected at the same time, the only thing that makes sense, you have to see what is in common in between all these organs. And the only thing common among all of them is a nerve, and that nerve called inferior hypogastric plexus that feed all these organs. So you have to go after that nerve and see what is going wrong with that. And in the case of endometriosis is the again implant of endo causing neuroinflammation on those network of nerve.
Let's talk about treatment. So we see some patients, even some young patients, who their symptoms were so severe that a doctor recommended removing their ovaries. Is that going to solve their problems?
Well, I would say this is a very old school way of thinking. Unfortunately, many decades ago, and unfortunately still we see that among many of our clinicians. The idea comes from this misconception that endometriosis is just hormonal condition. And the reason this myth or misconception exists is because you give this patient birth control or you suppress the ovary so symptoms temporarily get better. Is not a permanent fix. Patient feel better for a short period of time. So there is a correlation. When you shut down the ovary, symptoms get better. But it is very important to note that endometriosis is primarily an inflammatory condition. So if you suppress the hormone, the inflammation is still there and just gonna keep going. And therefore, we see this many times, and it's very sad that a very young patient come and a surgeon or gynecologist remove her ovary at a young age. And when I'm saying young age, even 42, 45 still is considered young age. And sadly, aligned with my theory, we see that their symptoms still persist despite of removal of the ovary. And that suggests that the nature of problem is not solely related to hormone.
So it seems like the answer is no. Removing the ovaries is not going to provide complete relief, and it's not the ideal treatment.
It's not just that. Removal of ovary prior to menopause have significant effect in a negative way on that woman's life, because the hormone coming from the ovary, which estrogen, progesterone, and testosterone, are extremely important for female body and for bone health, for muscle health, for many other conditions, including cardiovascular health. So therefore, removal of the ovary will have a significant negative impact in the whole body function. So it should be avoided by any cost.
Well, speaking of menopause, a lot of our patients hear that if they wait until menopause, all of their symptoms will go away because they're going to stop making hormones, they're going to stop having periods. Is that true?
So that's a very good question, and also is aligned with our previous talk about removal of ovary. The same concept. We see many women that have pelvic pain before menopause, with the hope that by menopause all the problem all of a sudden overnight gonna go away. Unfortunately, after menopause they continue to have problem, and the reason for it is, as I said, the nature of endometriosis is inflammatory disease. So because the inflammation is already established, these active mast cells that are just still functioning, this vicious cycle of and cascade of inflammation already started, will continue to damage the nerves and underlying structure. So therefore, patient gonna continue having pelvic discomfort, pressure feeling, urinary urgency, urinary frequency, bowel-related problem, bloating, and so on.
So after menopause, no, you won't have any more painful periods because you don't have periods, but you can still have pelvic pain and a lot of other pelvic floor dysfunctions.
Yes, absolutely.
Speaking of hormones, a lot of patients are put on birth control or oral contraceptive pills, and they either take them intermittently, where they have a week where they'll have a period and bleeding, or some people are told to take them continuously, which means they skip the placebo and they just never get their period. What do you think of that treatment for endometriosis?
The endometriosis is the endometrial glands sitting in the pelvic organ, so they are susceptible to hormone. So therefore, birth control have a role to regulate that, and also, especially when you use continuous birth control, it may suppress the growth of the endometriosis and also diminish those implant size. But if the inflammation already established with the cause of endometriosis, that inflammation is already there. So using birth control would not have any effect on that existing cascade of inflammation. Again, there is an inflammatory pathway that need to be addressed, and that at some point need to be surgical removal of the source of inflammation and the cause.
And in terms of surgery, some patients have the endometriosis burned off, while some patients have it excised or removed. Is there a difference?
Again, when you talk about the way endometriosis work is initial implantation, then the start of inflammation. So the problem is that inflammation. So now, if you have dealing with the inflamed wound, the best treatment would be to completely eradicate this area from underlying tissue, so that excisement and excising that would eliminate the continuation of inflammation. If you go and burn it, burning actually creates more inflammation. That by itself is another insult. Fulguration or burning is never a good answer. So that area needs to be excised. And in our practice, not only we excise the endometriosis, we adding a third level of care, which is addressing the underlying nerves. So those nerves need to be separated from the active implant, which is called neurolysis. In our opinion, I think that is also a third part and most advanced way of managing endometriosis.
Okay.
So burning, but also these small fiber of nerve, which are all functional and laying right under peritoneum and where the endometriosis sit. If you burn them, you're basically burning those nerves as well. So you're also making more functional problem for the pelvic area.
So speaking of these nerves, some of our patients who've had chronic pelvic pain for a long time, we see some nerve disorders with them. So they have palpitations, they have excessive sweating, they get headaches, they're constantly fatigued. Is that related to endometriosis?
Absolutely, yeah. So we talked about the chronic stimulation of the nerve when there is an active insult on the nerve, what will lead to hyperstimulation, hyperalgia, and then allodynia. So when this become persistent, then remember all the nerve travel from your back to the center. So these are peripheral nerves that are hyperstimulated. Then they travel to the central nervous system. We call that central hypersensitization or centralization, and then affect the central nervous system as well. So that's why symptoms like generalized fatigue, brain fog, nausea, excessive sweating, low back pain, and palpitation, orthostatic hypotension, these are all connected to the term central hypersensitization or dysautonomia. So these are all connected, and patient also anxiety is the other one, or migraine headache. So it is very, very common to see on endometriosis patients that have chronic pain for many years to have all of the above or some of these symptoms.
So it sounds like there's a lot with endometriosis. It's a very complicated disease, but we're learning a lot about it and hopefully better ways to treat our patients.
Absolutely. Please let us know if you have any question. You can always put on the comment and or reach out to our office if you have any additional question.